an interventional radiologist in Prince Sultan Military Medical Hospital, and he will talk about the lung metastasis ablation, a new approach and update. Please, Dr. Sultan, go ahead.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everyone. I would like to thank actually and congratulate Continuous Education Department for their success in e-learning activities during this pandemic. I would also want to extend my thanks to Dr. Faisal Al-Ahmari, Head of Division of Interventional Radiology, for his continuous support. So without any further delay, we start our presentation today, which is about lung metastasis ablation, present practice and updates. So the certain physiology about the lung, for example, the air environment around the lesion causing heat insulation and low electric conductivity is leading to the fact that the same amount of energy creating in the lung creates bigger tissue necrosis volumes than in other organs. Also, the fact that CT provides natural contrast between tumor, air, and adjacent structures leads to an adequate positioning of devices used for ablation. All this makes the lung the ideal organ for thermal ablation in the body. In the present, radiofrequency ablation is the reference technique of choice, being the most often used technique during the last 2 months, with many previously published series. It's considered a safe procedure with a very low mortality rate of less than 0.5%, sparing lung parenchyma and having an effective treatment. According to the common terminology criteria for adverse events version 4, most complications are minor, self-limiting, or even can be dealt with by interventional radiologists during the procedure. Most common are grade 1 and grade 2 complications, especially pneumothorax that can be dealt during the procedure, or emphysema and hemoptysis that are self-limiting. More grave or more major complications of grade 3 and grade 4 are are considered rare, less than 2%, and is mostly associated with other risk factors like previous chemotherapy, previous radiotherapy, and lung emphysema, especially in primary lung tumors. I would like to refer this to this large study published by Dubair colleagues in 2015, showing results of 1,037 metastases treated by radiofrequency lung ablation in 566 patients. The median overall survival was 62 months, with a very high local control of 89% at 5 years. So it was an excellent result. However, there are certain things to consider to maintain this quality of good result, especially careful selection of candidates. The diameter of lesion should be is preferably less or equal to 3 centimeters, and the number of metastases in each session, and this is in each session of treatment, should be always less or equal to 3. Should be at least 3 millimeters away from vessels, with electrode. DAT is the difference between the electrode and the tumor size. It should be more or equal to 10 millimeters. Especially short procedures should be performed in expert centers, and optimal follow-up should be carried. So we just mentioned about the DAT is the difference in size between the electrode times and the lesion, and it should be more or equal to 10 millimeters. Studies has proven that there was a statistically significant difference in technique efficacy rate when the electrode is larger and or less than 10 millimeters compared to the tumor size. So are there any limits of radiofrequency ablation? Is there any contraindication based on pulmonary function test, for example? Is there any defined precise number of lesions that can be treated in the same patient? Is there any defined number of times that patient can be treated by ablation? Is there any precise number of times a single patient can be retreated in case of recurrence? The answer of all these questions are no. There is no contraindication based on pulmonary function test, no defined precise number of lesions that can be treated in the same patient, no defined number of times, and no precise number of times a single patient can be retreated in case of recurrence, and we'll come to examples. So this is an example of a 26 years old male patient, metastatic sarcoma, 11 lesions treated over 2 years with 6 sessions, and patient had 3 years survival disease-free after this. We can see here fibrotic zones of after ablation of all these lesions scattered along the two lungs. So like any therapeutic option, there are limits, of course. Disease should be limited. Number of lesions in each presentation should be limited. A patient should be having only lung metastasis or at least lung-dominant oligometastatic disease. The disease must be stabilized by systemic therapy or at least slow-growing lesions. And of course, primary treatment should be definitely controlled before starting ablations of these lung tumors by resection. What about microwave ablation? We are speaking a little bit about radiofrequency. Microwave ablations has potential advantages when compared with the radiofrequency ablation. And at the same time, there are disadvantages. Advantages include that the temperature created by microwave ablation is very high. So the ablation time is shorter, and there is an independent of impedance of the surrounding tissue, leading to less heat sink effect. However, there is less predictability of ablation zones due to the high temperature created. So a larger zone can be created unpredictably. A larger lung parenchyma can be burnt. And there are numerous systems operating in different frequencies, so there is no unique or shared protocol for treatment between different operating systems. This is a study that was published in Journal of Vascular Interventional Radiology in 2017, showing that microwave ablation is safe and effective. But however, it had the same 3 centimeter efficacy, 3 centimeter of a lesion size efficacy, with a technical success of 11 times higher for tumor less than 3 centimeter versus tumor those that are more than 3 centimeter, and lower recurrence rate in the same group. So in brief, advantages of microablation include shorter in time and less intraprocedural pain. Disadvantages, smaller series available in literature, different manufacturer, as we mentioned, leading to different ablation zone sizes. Cannot predict safe margins compared to multi-tined electrode. The DAT that we described before, it can predict the safe margin by increasing the size of the electrode to 10 millimeter or more compared to the size of the lesion. Microablation, it's just an antenna with no tines. And the antenna of microablation is less stable compared to the tines of radiofrequency ablation needle, especially when there is patient movement or when creation of pneumothorax is needed to dissect the nodule from adjacent organs. Follow-up post-ablation, ideal exam for follow-up is the CT chest with contrast. Always keep in mind to expect increase in size in the post-ablation period due to inflammatory and hemorrhagic process and due to the increased ablation zone to acquire safe margins. So during the 6 months post-ablation, ablation zone is in all methods, either radiofrequency or microablation or even cryoablation. Ablation zone is supposed to exceed the size of initial tumor treated. So this is the initial tumor treated. This is before initiation of the treatment. This is at day 2, at 1 month, at 3 months after treatment. So always the size during first 6 months, usually exceeding the pre-treatment size of the nodule. Post-contrast, we should not have any contrast enhancement of the ablated lesion. Evolution after 6 months post-ablation, there are different evolution described in the literature. Can go to atelectic evolution, nodular evolution, fibrotic, cavitary, or even complete disappearance after 6 months post-ablation. So this is an example for atelectic evolution. That was the tumor at the time of treatment. Continuing and at 6 months follow-up, there was an atelectic band or subsegmental atelectasis of the treated zone. A nodular evolution showing that the nodule, and here we see that during the 6 months following the procedure, the ablation zone is still bigger than the nodule. So where is the we'll come to this. Where is the reference or the baseline exam that we'll be referring to and comparing further studies? It is the exam of first month after ablation, and we'll come to this. It will be the baseline exam. So this is a nodular evolution 6 months after the ablation, fibrotic evolution up to 6 months, and criteria suggestive of recurrence when there is any contrast enhancement, a threshold of 15 to 25 units. And there is a suggestive role of dual energy CT in the future and MRI. If there is increase in size, as we mentioned, compared to the CT of first month after treatment, which is the baseline CT. When there is a nodular eccentric or irregular component, for example, this is a CT that was done 18 months compared to 1 year after ablation. All these are suggestive criteria for recurrence. So in general, recommendations for follow-up, CT is the preferred modality for follow-up after lung ablation. CT at day 2 is required to measure the ablation zone and monitor complications. The baseline image, as we mentioned, is the CT after 1 month, in which the future imaging will be confronted to. For the first year, CT will be needed every 3 months, then every 6 months. And there is no role of PET CT for during the first 6 months due to the false positive result that can be created, or the inability, actually, rather than false positive, inability to tell which is which, if it's non-treated segment or if it's only inflammation post-treatment. And there is a suggested possible future role of MRI and dual energy CT. I'll just go through two articles. This is the first article, though it was an old article, 12 years old, but there's a lot of information that can be driven from this article, and most use of radiofrequency ablation in the lung nowadays are driven by this study, the Raptor study. It was the first prospective multi-center trial for ablations of lung tumors between 2001 and 2005. In 106 patients, 183 tumors. Unfortunately, it was mixed bag, not only metastatic, which is our subject of today. There was always, as well, 33 non-small cell carcinoma with the lesion sizes of 1.7, of a median of 1.7 centimeter. The technical success rate was 99% in all tumors, and the complete response was 88%, with complications of minor complications of 19% that are most of the time dealt in the same session by interventional radiologists, which were mostly pneumothorax and pleural fusion that were drained, and no death in all patients due to procedure. So this is the overall survival in the three groups, the metastatic groups, the red and light blue, red being the colorectal metastatic patients, the light blue other metastases, and the dark blue were the non-small cell carcinoma patient. Overall survival, there's some favorable survival in the metastatic groups compared to the non-small cell lung cancer group in overall survival. However, the cancer-specific survival was equal in all groups, and this is expected when we consider the comorbidities in the primary lung tumor groups, for example, COPD or vascular disease in non-small cell non-small cell lung carcinoma patients. Most of them are smokers. The other study that I would go through enlighten part of the enlighten us over the on the clinical perspective. Usually, the metastatic colorectal cancer patients are patients who are facing several lines of chemotherapy. They are sick of the chemotherapy. They want break from time to time. So this trial studied retrospectively 209 patients that had 630 lung metastases treated by ablation. So about a median of 3 metastases in each patient. 19% of patients had liver metastases as well. They were treated by multiple means, heterogeneous pre-treatment protocols of different lines of chemotherapy and surgeries. And it showed a median of 12.2 months of chemotherapy free survival or chemotherapy break that extended to even about 2 years in patients who presented with only lung metastasis. At the end, I like this case. This was a case I was involved in treatment of some sessions when I was in France. This shows the importance of selecting the right treatment in the right time. This patient was a 29 years old male patient with rectal CA at time of presentation of his primary tumor. He was T3N1. He was resected in January 2009, rectal CA. So 1 year later, patient presented with 6 bilateral small lung metastases. All 6 bilateral tumors were ablated with adjacent chemotherapy. Following 2 years, lung metastases were popping up every now and then. He had 4 sessions of ablations. First session, 4 METs were treated. Second, 2 METs, 1 MET, 1 MET. So in total of 12 metastases were treated during this period by ablation, 12 metastases and 5 sessions. August 2012, he presented with this solitary central metastasis, which had invasion of vascular and bronchial structures, making it non-suitable for ablation. However, patient was metastatic free elsewhere. So he was at that time candidate for surgery. He was operated, he had the left lower lobectomy, and after till the last time I followed this patient, 3 years post lobectomy, patient was still disease free. So just imagine if we have not been radical here with ablation therapy, patient would not have been alive at this stage in August 2012. And at the same time, if surgery was started here, he wouldn't have there wouldn't have been a role for surgery here, so, or an option for surgery. So always we have to remember that ablations need to be moved higher in the management of algorithm in clinical practice for appropriate patients, especially that efficacy and safety are well understood, and there is a very high local control in small tumors. And the ablation of multiple metastases is very well tolerated, as we all seen. And there is no other treatment that can begin to compete for the complete eradication of multiple bilateral small tumors. Thank you for listening. That's all.
Thank you, Dr. Sultan. I have a small question. If you regarding the prognosis after the ablation, is there any certain tumor from primary tumor with the lung metastasis? It's the effect of the ablation. It's different from the other primary, like if you have colorectal compared to the renal cell, or the results of
usually the studies proven that the colorectal metastasis, lung metastasis, has the best post ablation survival compared to the non-colorectal. However, there was no really significant difference in overall survival. And compared to, as we mentioned, in lung tumors, there was, or primary lung tumors, there was difference in overall survival, but there were no difference in cancer-specific survival. And this was usually explained by the other comorbidities affecting the overall survival in primary lung tumors.
We are in liver, like liver and kidney. We are doing ablation as a curative management. Is that it? You will apply it in the lung as curative?
Lung, yes, it's considered as it is considered as radical ablation therapy. Yes, local radical ablation therapy.
I think there is no question. I double check with the question and answer. Nobody, I didn't see any questions. I think we will close our session. And thank you very much, Dr. Sultan, for nice and very informative presentation. Inshallah.
And I would like to, after your permission, I would like to just according to the education department, continuous decanshment. They mentioned that there will be a link sent to you to fill the evaluation of this presentation. Thank you so much.
Thank you very much. Thank you.